Hello, I'm Jim Hermiller from the St. Vincent Heart Center in Indianapolis, Indiana. I'd like to welcome you to this program titled The Role of Bioabsorbable Abluminal Polymer-Coated Stents. Joining me today at the TCT meeting in Miami, Florida is Ian Meredith. Ian's professor of cardiology and medicine and director of Monash Heart at Monash University in Melbourne, Australia. We also have Dr. Sigmund Silber, who's professor of medicine and cardiology at the Cardiology Heart Center at Eisenpraxis Hospital in Munich, Germany, and Dean Kariakis, who's medical director of the Christ Hospital Heart and Vascular Center and the Carl and Edith Lindner Center for Research and Education at the Christ Hospital in Cincinnati, Ohio. So I think just to open things up and kind of a roundtable discussion today, maybe weigh in on where we are with the durable polymer-coated stents that we have today, limitations, what is it that we'd like to see that would be better? Ian, you want to kick it off?
Thanks. I think we'll probably all have comments to make here, but obviously we have recognised from histology studies and from clinical studies that conformable durable polymers probably do lead to a background residual risk of late stent thrombosis and very late stent thrombotic events, partly because of inflammation, maybe partly because of malapposition of stents, but the durable polymers do give you chronic ongoing inflammation that increases your risk of late events and neoatherosclerosis. So the desire to look for an alternative, either no polymer at all or minimal polymer load, seems a very reasonable next iteration for drug-eluting stents.
Yeah. Well, I agree with that. But we have to differentiate in the durable polymers, maybe the first generation and the newer generation durable. So there was a considerable progress, even with durable stents, with better long-term results than the first durable drug-eluting stents. But still, there's always something in your mind that the durable means forever. And I think we as physicians, if we implant something for the patient for the rest of his life, we would rather have something which disappears slowly just to make sure it won't stay forever. However, we need more data on that, of course.
Mm.
I agree, Jim, but I think we've come a long way, and particularly with the PVDF fluorocopolymer, we've seen data, both a direct examination trial and a comparison, and in meta-analyses, Paul Marini and Bangalore, where you have a lower risk, a lower hazard of stent thrombosis with a PVDF-covered EES than you have with non-EES DES, and also even with bare metal stent, and that's really been a hot topic. Is the PVDF polymer better than bare metal stent at the end of the day?
Right.
Having said that, though, that we've still got evidence, even with PVDF, that late stent thrombosis and very late stent thrombosis events occur, albeit at a much lower risk, and probably the annual risk is in the 0.5% to 0.7% range, but in high-risk populations, I think, Dean, you'd agree that there is still a background risk of events even in these high-risk patient populations.
Absolutely, but I second it. I think bare metal stent got off scot-free. They got a hall pass. There is, as you saw in a Mayo Clinic series over 10 years, incremental between 1 and 5 to 10 years for bare metal stent, particularly with off-label use, stent thrombosis.
But I think the key for this discussion is long-term results. Yeah. I mean, we've seen from many studies that some curves separate after 3 years, after 4 years. So durable polymer, we need maybe 5 or 10 year long-term results. Again, I think the idea of something is dissolving just makes me feeling better.
Right. And I think we're all focused on very late stent thrombosis, and this issue of neoatherosclerosis is something that down the road we're going to face.
Yeah, that's right. Now, I think to Dean's point about bare metal stents having very late clinical events, so part of that is neoatherosclerosis, and it may be due to all of these issues that we've discussed previously about stent strut thickness, malapposition, all of those things that would alter endothelial function because of changed shear stresses. So there's a combination of things that lead to late clinical events. Do you agree?
Yeah. So let me ask this. In terms of bioabsorbable polymer coated stents, in the U.S. we don't have any, but certainly the rest of the world does. And wonder, just comment, what's the uptake been, and in your practices and what you see?
Well, probably Sigmund is better to speak to that because they are, many of these are actually CE marked and being used in the US. In Australia, they're a part of clinical trials.
It's my pleasure that I'm the only one here actually using the devices which we're talking about.
Right.
So of course we have practical experience. In Germany, we have 4 different drug-eluting stents with bioabsorbable polymer approved. The one is the Nobori, which is similar to the Biomatrix Biolimus-eluting drug-eluting stent with an absorbable polymer. And the other one is the Biomime, just a new kid on the block from India with sirolimus-eluting. And the 4th one is the Ozero, which is also a sirolimus-eluting bioabsorbable polymer stent. We use all 4 of them, and so far we have, I would say, good results. Of course, we have to analyze the data. Some operators have the preference for one, some operators have the preference for another one. So for us, it's more the decision, shall we use a sirolimus-eluting or a biolimus-eluting drug-eluting stent. But we stopped, of course, using the first generation durable polymer stents.
Any particular patient subgroup that those are being used today? Or?
No, I think we just have to gather experience. But I think for all drug-eluting stents, it was still very hard to show that one specific patient population is suited for this or that drug-eluting stent. I mean, even for diabetes, there was a lot of discussion. I mean, in the United States, I think only the Resolute is approved for diabetic patients. But what is your experience with this?
Now, I don't know that anyone has a magic effect or differential, preferential that can be proven, statistically in diabetes. I think diabetes are bad actors. Diabetics in general have higher event rates, higher restenosis. But I chaired a session yesterday where there were at least 10 different bioresorbable polymer-coated metal platform stents. And I got to look very carefully at polymer load and the rate of bioabsorption, how long it takes. Almost every one was 6 to 9 months, some over a year, and some of them had larger loads, which is one of the determinants of that. And clearly the shortest, meaning the thinnest, 4 microns with bioresorption within 3, possibly 4 months, was Synergy. And so that model, PLGA, best polymer is one that does its job and it goes away. That would be a great concept.
I agree. And the other thing about the polymer loads is the degradation of a polymer is actually an exothermic reaction. So you actually have to generate some heat and acid and cations. So you want something to disappear quite quickly with the least inflammatory reaction associated with the degradation of that polymer. So not all abluminal bioerodible polymers are necessarily desirable.
Right. And this really gets to the kind of the question of, besides very little polymer, one that does its job and gets out, what other sort of design elements would you say, hey, this is what I'd like to see in sort of the next generation?
I mean, the question is, what do I expect from this technique? What I expect is a shorter duration of dual antiplatelet therapy. So if the new stent can show that even with a shorter duration of drug release and a shorter duration of the polymer sitting on the stent, you can reduce your dual antiplatelet therapy at least for 3 months. That would be fantastic, because right now the European guidelines say still 6 months. There was a lot of data showing at least 6 months. The Americans say at least 1 year, although I think there's no data to justify this at least 1 year rule. So I think what we need is not only more efficiency in newer drug-eluting stents. It's hard probably to meet the big top drug-eluting stents regarding efficiency. Well, you can always do better, but I think what we do need now is not only, if possible, more efficiency. We need more safety with a shortened duration of antiplatelet therapy.
Can I make one subtle distinction there? I think you're right about the shorter duration of dual antiplatelet therapy, but we also need to reduce or diminish the perception of dependence on dual antiplatelet therapy and the angst associated with that dependency, because most of these patients are ending up having some form of surgical procedure. As you know, being in your role in the Resolute studies, somewhere around 15% of patients have a surgical intervention that was unplanned. and you have this whole issue of
I would feel better if I have the kind of reassuring that just in case you have to stop to antiplate, that it's not a big catastrophe.
Yeah, exactly.
But we need this reinsurance.
It's a much broader view that we have now, I think, than previously.
Yeah, but after all, the conformance of the stent, it will end up in efficacy and safety. So these parameters are still valid.
Yeah, very, very.
May I be a little bit provocative?
Yes.
Or is this
Yes.
allowed? Okay, because the Americans talk all about the DAPT study. It's a huge study. It's the largest study, over 20,000 patients. I think it's. I have to admire you to perform such a study with over 20,000 patients. But, and here comes my but. The patients are randomized after 1 year of dual antiplatelet therapy. And I'm personally not so much interested because after 1 year, I mean, anyway, we discontinue after 6 months according to the European guidelines. So if you stop or continue after 1 year, this is really not our everyday practice.
Luckily, we have the PI here.
European guidelines written without a definitive adequately powered trial, which will be ISAR safe.
Well,
ISAR safe 6,000 patients will be adequately powered to look at the 6 versus 12 months. I think it's complementary with DAPT, which, based on the U.S. guidelines, was at least 12 months. And so hence, at 12 months, we randomize. And the test is really 30 months versus 12 months in the DAPT trial. I think ISAR safe is going to be the study that will determine 6 versus 12
they
months.
randomize after 6 months,
Yeah.
then 6 versus 12 months. But what I would like to see is 3 months versus 6 months. We are shifting what we emphasize on. In the previous days, we talked about late safety, not efficacy. Efficacy was okay, but late safety. Now we are switching. We are talking no more about late safety. We're talking more about late efficacy. So I guess that this is what we would expect from the newer stents. Because, as you said, with the newer generation durable polymer, the very late stent thrombosis is not an issue anymore. But the very late efficacy would be very, very interesting to see.
There are about 8 reasons why one would hypothesize that a completely bioabsorbable platform might have an advantage.
Oh, absolutely.
But until proven.
Yeah, it has to be proven.
But before it's proven, actually, I think I'm the only one who can use it today. So because the Absorb stent is CE marked, it's available. Abbott sells it already. We have to go through an official training course just to make sure it's not too calcified lesions and not too much torque with too much bends around the vessels. But it's going to be a very, very interesting thing. The only problem is the price. I mean, it is the price much higher than the average drug-eluting stent, and we have to see if the healthcare providers will take over.
And very frankly, the target for Absorb 4 was superiority from 1 to 5 years. So, and that's been out. This is public knowledge. But the point there is that 2.6% TLF per year. Can you beat that?
So less is more, is what I would say.
Yeah. Sigmund?
Yes. Well, we've got a long way. Stenting, bare stents, drug-eluting stents. Of course, I would rather prefer to implant something which is disappearing. The problem we have is that to answer these questions, it may take 4 or 5 years. But I have to make today's decision already. So we have to have the guts to implant something in the patient, and we know that the data is coming out later. But we did this before, so I think we were pretty safe with this way.
Dean, you get the final word?
Yeah, in a bullet. Acute performance, impart flexibility, conformability, profile. I want something that helps me do tough cases, not makes it more challenging. And at the end of the day, I want something I believe that we can drive down what we now know to be the objective late failure, if you will, TLF rates of the current best-in-class stents. I think we have strategies. These strategies are going to be tested in the next several years, and it'll be a very exciting time.
Well, that's great. Well, I want to thank everyone for participating. Thank our distinguished panel. This was a great roundtable. It's been provocative, I think informative. And you may now take the CME post-test by clicking on the Earn CME credit link. Please also take a moment to complete the program evaluation that follows. And I want to thank really everyone for participating today. Thank you so much.